So I would just, a quick comment, I've done the genetic test, I've also done 23andMe, which tests for like 200 plus things now. The most important thing I would convey with the genetic test is you can never not know it. Once you get the answer, you cannot take that back. So it's knowledge you can't get back once you get it. So it's really important to think it through. My question goes all the way back to the beginning of your talk, where you were going through the genetics and the DUX4 thing. You talked about DUX4 as if it was an absolute certainty that is like the central nexus of the disease. And from my understanding is that there's a lot of sort of weird research, some showing that people who have expressed DUX4 don't show any signs of FSH. People without DUX4 expression show FSH. Just curious what the thought here is in the room as to how confident we should be in that central role of DUX4.
Yeah, so the question is in a nutshell, is how sure are we that DUX4 is the key? And we're not 100% sure yet. So, because there still are controversies. So why is it that only 1 out of 1,000 muscle cells shows DUX4 expression? And why do some people with FSH, why can't they find any DUX4 expression? So we don't have it all figured out, and it probably is because DUX4 is part of a pathway, a cascade of other genes being turned on or turned off. It seems like all evidence is pointing towards that we're in the right direction with this pathway, but that DUX4 isn't necessarily the answer, but we've gotten closer to getting to that answer. And it might not be one single answer, because epigenetics, so this term epigenetics refers to reversible modifications to our genes in our DNA. So it's not a mutation or a change in the DNA sequence itself, but it's some other modification to it. And epigenetics is influenced by other genes and in the environment, so it's probably a combination of things.
Thank you.
Yes, absolutely.
And thank you to everyone else for that.
Yeah. Yeah.
I'd like a two-part question. My first, I don't know if I'm understanding right, but mother to son, does that make the muscular dystrophy worse?
So question about is there any difference between mother to son transmission? So there was some thinking, or there was an observation that sons born to mothers with FSH tended to be more severely affected. That hasn't panned out. There isn't any genetic reason for that, so it's not, this is on a numbered chromosome, so it's not on the X chromosome. And we're not sure really why it is that there was that observation that sons of mothers with FSH would be more severely affected. We don't have any genetic explanation for that, and there's lots of debate. What's that?
That's just like a big rumor.
I don't think it's a rumor. I mean, I think it's a real observation. You know, I've read about that as well, but it might just be.
It's not an absolute rule. And so
Yeah.
I think that is what is why we really feel very cautious about saying that that's what we observe, because we've seen, daughters who are also very, very severely affected, and we've kind of seen the reverse, is that the children are not quite as necessarily as bad as the parents. And so I don't think that that's, and that is something I think some people have observed, that there are some, women who have FSH who have very, very severely or infantile onset FSH. At the same time, you can't use that to actually predict what is going to happen in the future to any of the people involved. And so, and so, I'm kind of, I would be cautious about sort of
making a decision.
That is a declarative
Right, and
statement.
Yeah.
then my other, two things, was we can't kind of base our own experience of our personal life of muscular dystrophy, or how not, sorry, I jumped right here, but how we felt like it was mild, or what, as far as having children, because we can say like, mine wasn't very progressed, so my child's wouldn't be, or my life was very good, so our own personal experience is nothing compared to if we were to have a child.
Right, we
It's
just
not going to
can't,
be lessened, or we don't know if it's going to be worse, or we can't predict.
we can't predict. So a person who is more mildly affected or hasn't affected them in so many ways, or is later onset, they could have a child who is the same or more severe or more mild. And it's frustrating that we can't give more concrete answers and predict. but we can't. In some genetic disorders, it is disease runs true in the family. So the parent and the child have very similar severity, similar age of onset, but it's not the case in
So
FSH.
it's nothing we can kind of.
Right. And the way that I think about it is that even siblings, if there's a family with a large number of siblings, there can be a huge amount of variation between how well one is doing and how well the others are doing. And
Yeah.
so theoretically, they inherited from the same parent. And
Right, and that was my next question.
Mhm.
Now, I have a brother who has muscular dystrophy, and he's had children.
Mhm.
And we don't know if they have gotten it, or carriers, or however you want to call it. We're not waiting to see if they do get it. If they do get it or do not, should his children be tested before they ever have children?
So what I always say is that a person should know about it before they have children. Not that they need to get tested, but that they can make an informed decision as to whether or not they would want to have testing.
But wouldn't they possibly be carriers because the father had it?
Right, exactly. So what I would say is when those children are old enough, when they're teenagers, they could, if not earlier, start the discussion, hey, son, I have a form of, muscular dystrophy, and sometimes it could be passed on. So, starting the conversation so that they can know that they're at risk and could make a decision about being tested. But I don't think that everybody at risk should be tested, because that might not be the right thing for them at that point in their life. But just be able to be informed about that. Because it's not going to change their plans for having children of their own, and if it's not going to change their plans for how they're going to live their life, then maybe they say, I don't really need to know. I'm fine. Like, I know I'm at risk, but I don't need to know for sure. Yeah. People feel differently about it.
I think as long as they're, one of the things like Don pointed out, once that information is out there, I think a lot of people think of just, whether or not they're going to have another child or whatever. Obviously, you want to have as much information. I think a lot of people forget about the insurance side of it. Once, a child doesn't have, or if they're diagnosed with it as a child, it can really change the financial side down the road as far as life insurance, things like that.
Yeah.
That people don't think about because
Long-term care.
long-term care, things that, once that information is in a database, they can be denied for a lot of things, even if they're not manifesting. So, I think those are the things that people should look at from just beyond the health standpoint. Once that information is out there, and a child may not ever progress as far as manifestation.
Right.
So those are some other aspects to
And
think about.
in our own counseling experience, we really do feel that people own their own genetic information, and just because they're minors doesn't mean that isn't true. I think it's we should allow people to know it or not know it based on how they feel that whether or not they want to or not, and they should be informed about what their possible risk is. But we would never go along the lines of saying you should get this or you should get genetic testing. It's about understanding what your options are and making a decision that you're comfortable with.
I mean, there's no benefit from a health standpoint as a minor for them if they're not showing any signs.
Correct.
Correct?
Correct.
So if I have a 14-year-old daughter who doesn't show signs, I mean, there's no benefit to having her tested at this point.
Right, exactly.
Until she's old enough to, obviously say, oh, I have kids or not have kids.
Yeah.
But let me ask you on that, say, my niece, she's 14, don't you think it's, I don't know, maybe I'm in a different world here, but I should teach her that her father and I both have muscular dystrophy. I would not want her to have a child and experience and go through that. I would want her to have testing so that she could go through like all the procedures we're talking about, so that she could have a healthy child, so she wouldn't have to go through all, if there are these things out there.
But that's her choice.
Well, that's why I'm gonna give it to her, to inform her, and let her know what these things are, because if you don't teach them.
Yeah, so it's appropriate to have conversations with with the kids and as they're teenagers in an age-appropriate way. And then when they're adults, then they can have the option of genetic counseling and genetic testing. But secret keeping can do more harm than good. But we wouldn't say that, oh, she should be tested right now, just so we have, yeah.
Testing, I'm saying, talk to her, this is what I have, this is what your father has, and you might wanna do this when you're older to make sure that you can have healthy children. And, cause like you said, to have a child that has a disability, and so it changes your whole world, the insurance,
Yeah.
I would just add, just from my own personal experience, that I feel that I was just really lucky to be diagnosed at 19 and not really to know what the symptoms really were when they started to manifest between 16 and 19. I mean, I led a really normal and active life, downhill skiing, basketball, everything, and that slowly started to change. So, I think when they're adult, in just my own opinion, when they're adults or they're at a point where life decisions could affect a relationship with a potential future spouse or the possibility of kids, that kind of thing. But in the teen years, they seem to be, based on my experience with my nieces, other people that have teenagers, life is complicated as it is. And I feel like we feel very fortunate that we were kind of able to kind of kill this with me, so to speak. But not everyone had that option in prior years. We wanted to make the choices we made, but it was a luxury that I had to be 14, 15, 16, 17 and not have a clue. And it sunk at 19 when I found out. But
there is the opposite side of this too. You've said several times now that even if we know there's nothing else we would do differently, right? I mean, FSH is very prevalent in my family. When I was 15 trying to do the president's physical fitness thing, and I couldn't do a pull-up or a sit-up, there was comfort in knowing that there was a reason why that was. And then also in knowing, while there's nothing medically we could do, it did set me on a course in life that allowed me to sort of say, I'm not going to wait, because I don't know how long I have to walk. I don't know how long I can do the downhill skiing or the water skiing or all of the things that I did, traveling around the world or living on a boat. Many of those decisions derived from knowing that I had this affliction and that every day was one more day that I didn't know whether I'd be able to do that. So to say there's nothing else you would do differently, I think is a little bit focused only on the medical side. There is a tremendous psychological side to this disease as well.